Welcome. Now we're going to get into how a patient's chart is actually organized, which is one of those topics that seems dry until you realize you'll read and write in these formats every day. We will cover four things. First, the two main ways to organize a whole record, the source-oriented medical record, or SOMR, and the problem-oriented medical record, or POMR. And we'll break down the POMR into its parts. Second, the SOAP note, what it is, what each of the four letters stands for, and how it's used. Third, the difference between subjective and objective information, which is one of the most tested distinctions in this course. And fourth, this Cheddar format, which expands on SOAP. Keep your guided notes open, fill in the blanks, build a SOAP note, sort subjective from objective findings, and label the Cheddar letters. You'll upload those notes to Brightspace for credit. Let's get started. Here are your learning outcomes. By the end, you should be able to do 5 things. First, compare the two big ways a record is organized, source-oriented and problem-oriented. Second, identify the parts of the problem-oriented record and what each part holds. Third, explain what a SOAP note is and what each of its 4 letters means. Fourth, tell subjective information apart from objective information, which sounds simple but trips people up constantly. And fifth, describe the Cheddar format and its 7 parts. Notice these build on each other. The POMR gave us the problem list, and the SOAP note, SOAP, gives us subjective and objective, and Cheddar expands on SOAP. So by the end, these will all connect. Keep these goals in mind as we move through these slides. Before we get into the specifics, here's the big idea. Every clinic needs a consistent way to arrange the record so anyone can find information quickly. 2 formats dominate, and the difference between them comes down to one question: how is the information grouped? In the source-oriented medical record, the SOMR, information is grouped by who supplied it, meaning the source. All the lab reports go together, all the provider notes go together, all the hospital records go together, and within each section, entries are kept in chronological order. You will also hear the SOMR called the conventional record because it is the traditional approach. In the problem-oriented medical record, the POMR, information is grouped by the patient's problems instead. The record is built around numbered problem list, and everything related to a given problem is tracked together. This format was created by Dr. Lawrence Weed in the 1960s, and we will spend the next few slides on it because it gave us tools you will use constantly, including the problem list and the SOAP note. So as we go, SOMR groups by source, POMR groups by problem. Let's look more closely at the SOMR. The defining feature is that information is filed by its source, meaning the department or person who supplied it. So there is a section for provider notes, a section for lab results, a section for radiology, a section for hospital records, and so on. Within each of these sections, entries are arranged in chronological order. All of a patient's problems and treatments may show up together on the same forms, mixed in by date. This is the traditional layout, which is why it's called the conventional record. Now the trade-offs, because this is where exam questions live. On the plus side, the SOMR is simple to set up and maintain, and if you want to see everything from one source, say all the lab work, it's easy because it's all in one place. On the downside, it's hard to follow a single problem over time. Imagine a patient whose knee pain comes back 3 years apart. In the SOMR, the first episode is buried in an old section and the second is in a newer one, so the provider has to hunt through the chart to connect them. That difficulty in tracking one problem is exactly the weakness that the problem-oriented record was designed to fix, which is what we're going to discuss next. Instead of grouping by source, the POMR is organized around a numbered problem list. Every problem the patient has gets its own number and the date it began, and then all the data, plans, and notes related to that problem are tracked together under that problem. The payoff is exactly what the source-oriented record struggled with. You can follow a single problem cleanly across many visits and many years because it all lives in one place. This format was introduced by Dr. Lawrence Weed, often called Larry Weed, in the 1960s. He was a physician who watched students struggle to make sense of disorganized notes, and he reasoned that organizing the record around problems would mirror the way a clinician actually thinks. Two of his inventions became nearly universal, and you will use both, the problem list and the SOAP note, which we will cover shortly. So remember the name Lawrence Weed because he shows up again when we talk about SOAP. Next, we'll open the POMR and look at its parts. There are several parts to the POMR, and we'll take a look at them in the next two slides. The first part is the database. This is the baseline information gathered at the very start, and it includes the health history, the physical exam findings, and the initial lab and test results. Think of it as the foundation that everything else is built on, and notice that gathering much of this database, like the history and vitals, is your job as an MA. The second part and the heart of the whole system is the problem list. This is a numbered master list of every problem the patient has, and each problem is logged with the date it began. It is literally the centerpiece of the POMR because every other part connects back to it. The third part is the diagnosis. For each problem on the list, the provider identifies the condition, drawing on the database and the exam findings. So the flow so far is collect the database, build the numbered problem list, and assign a diagnosis to each problem. On the next slide, we'll cover the planning parts, treatment, patient education, and the progress notes that track how each problem unfolds. Here are the remaining parts of the problem-oriented record, the parts that turn a diagnosis into action. First is the treatment plan. For each problem, this is the planned care, the medications, procedures, tests, and referrals the provider orders to manage that specific problem. Second is patient education. This captures what the patient is taught about the problem and how to care for it. Things like medication instructions, lifestyle changes, and the warning signs that should prompt a call or a visit. Documenting education matters because it shows the patient was informed and you will often be the one doing and recording that teaching. Third is the progress notes. These are dated notes that track each problem over time, recording the patient's condition, the treatment given, and importantly, the response to care, whether the problem is improving, is stable, or worsening. Notice that the progress notes are where the SOAP format usually lives, which is our perfect bridge to the next section. So the full PMR is database, problem list, diagnosis, treatment plan, patient education, and progress notes, all organized around the numbered list of problems. SOAP note is the format you will see and write most often. A SOAP note is a structured way to write a progress note, and like the problem list, it comes from Dr. Weed. It is used at each visit to organize the provider's critical thinking into 4 parts, and the letters always go in order. S is for subjective. This is what the patient reports, their symptoms, their feelings, and their history told in their own words. If the patient says, "My stomach hurts," that goes under S. O is for objective. This is what you observe and measure, vital signs, physical exam findings, and test results. A blood pressure of 140/90 or a temperature of 101 goes under O. A is for assessment. This is the provider's diagnosis or clinical impression, and it is reached by synthesizing the subjective and the objective together. P is for plan. This is what happens next: the treatment, any tests or referrals, the patient education, and the follow-up. So SOAP moves logically from what the patient tells you to what you find to what it means to what you will do. That subjective versus objective distinction in the first two letters is so important that it gets its own slide. That's coming next. Subjective and objective information is a distinction students miss most, so let's nail it down now. Subjective information is what the patient feels or reports, and the key is that you cannot measure it directly. You rely on the patient's description. These are symptoms like pain, nausea, dizziness, or fatigue. If the patient says, "My head has been pounding since yesterday," this is subjective because only the patient can feel it and describe it. It will go under the S in SOAP. Objective information is what you can see, feel, measure, or observe, ideally with an instrument. These are signs like a temperature, a blood pressure, a rash, or a lab result. A temperature of 101.4 or a blood pressure of 150/94 is objective because it can be measured. It goes under the O. Here's a memory trick at the bottom, and I want you to write it down. Symptoms are subjective. The patient describes it to you. Signs are objective. You observe or measure them. Subjective data is descriptions from the patient. Objective data is observations from the healthcare provider. One more nuance. When a patient says they have a fever, that statement is actually subjective, but the thermometer measurement reading that you take is objective information. Same situation, two different kinds of data. Getting this right is essential for writing accurate SOAP notes and for the certification exam. Our last format is Cheddar, which you can think of as SOAP on steroids. Where SOAP has 4 parts, Cheddar breaks the visit into 7, which makes it useful when thorough documentation matters. For example, billing and coding. Let's walk through the letters. C is the chief complaint, the main reason for the visit, captured in the patient's own subjective words. H is history, the past medical, family, and social history, plus the history of the present problem. E is examination, the objective findings from the physical exam and the body systems the provider checked. The first D is details, the specifics of the problems and complaints, like when they started, what they feel, and things like that. The second D is drugs and dosage, a list of current medications with their dose and frequency, and any changes the provider makes. A is for assessment, the provider's diagnosis or impression, just like in SOAP. And R is the return visit, the follow-up plan, return visit information, or a referral. Notice how Cheddar maps onto what we already learned. The chief complaint and history are largely subjective, the examination is objective, and the assessment and return visit mirror the A and P of SOAP. So if you know SOAP and you know subjective versus objective, Cheddar is just a more detailed cousin. Now to summarize this lecture into 5 takeaways. 1. The 2 ways to organize a record differ by what they group by. The source-oriented record groups by source and date. The problem-oriented record groups around a numbered problem list. 2. The POMR has a set of parts and you should be able to name them: the database, the problem list, the diagnosis, the treatment plan, patient education, and the progress notes. 3. The SOAP note structures a progress note into 4 parts in order: subjective, objective, assessment, and plan. And it came from Dr. Weed along with the problem list. 4. The distinction to lock in. Subjective data are the symptoms the patient reports, and the objective data are the signs you observe or measure. Symptoms subjective, signs objective. 5. Cheddar is a more detailed format that expands SOAP into 7 parts: chief complaint, history, examination, details, drugs and dosage, assessment, and return visit. Master these and you will read and write charts with confidence. Don't forget to complete your guided notes and the self-check and upload them to Brightspace. Here are the resources that I used to put this lecture together. Feel free to dive in deeper, find more information about the topics covered in this lecture today.